I would like to tell that what is the most important thing when you are preparing a topic or preparing a subject or preparing an exam. You just have to think that if, for example, any question is being asked, you have some words to say. Okay, that's why I just stress on some common things which can save you. Like for example, I say that my best friends. Okay, like if you forget, you can tell that normoxia, normocarbia, normothermia, normovolemia, normotension. Okay, so avoid sympathetic stimulation, sinus rhythm. Okay, so this is the thing which you can say in any anesthetic management, and your answer will be correct. Okay, so similarly, whenever you are preparing any subject, you just try to have. That's why I request all of you to have a look on all the articles which are published on that topic. Okay, so it's not necessarily that you need to cram each and every line of that particular article. You just can scan, and if something, like I give you an example, that when we were preparing for Irish fellowship exam, I just searched, and one of the topic, we found a topic which was not written very nicely in majority of the books, is awake craniotomy. Okay, it's not written, although it's not something out of the world, it's a very simple topic. But believe me that awake fiber optic is coming on my mouth again and again. Awake craniotomy came in our exam. Similarly, there was a topic fibromyalgia. It's written a number of places, but we just read an article. There was a topic of this one, this CRPS. There is a Budapest criteria. So that question was asked. So what I will tell you, that don't try to look into too much details. This is one, and don't bypass any topic in which you cannot speak at all. Like if you forget anything about muscular dystrophy, you can say that there will be some sensitivity or resistance. This should be in your mind, that any muscular dystrophy will have problem with some muscle every any muscular dystrophy, there will be some problem related to cardiac system. Okay, so things like that. So maybe if you miss molecular or microscopic details of that topic, yes, that can still if you know the basic theme of that topic, you will be able to talk something. Okay, so that's my message. Don't miss anything, actually, because any topic can be asked. Okay. Okay, so now we will start with today's topic. So, to start with, what is anemia? This is the bread and butter of any anesthetist. So if someone asks you what is anemia, how can you just start the answer?
It is a condition in which the number of RBCs and the oxygen carrying capacity does not able to meet the physiological need of the body.
Okay. Anyone else? Tayyaba, how can you define it? Okay.
So anemia is basically a clinical condition in which the hemoglobin levels are below, which are being specified for that age and sex. For example, 13 milligram per deciliter for male and less than 12 milligram per deciliter for male, according to the WHO criteria.
Okay, you are absolutely right. Like age, sex, or clinical condition. Okay. Like you will label according to the that stage of his life or stage of his clinical condition. Yes, Bilal. Bilal, you have raised a hand. Would you like to say something? You have to unmute yourself. I think nobody can hear you.
Okay. So for anemia,
We cannot hear you, Bilal.
probably.
You have to restart your statement.
Hello.
We couldn't hear
Hello.
you before. Yes, yes. Now we can
Yeah.
hear you.
Can you hear me now? Yeah, yeah. So the concise definition for anemia is the decreased hemoglobin concentration below the reference range according to age, sex, and distribution. The reason is that the anemia cutoff value is different for blacks and non-blacks. Cutoff value is different for gender. It's different for adult, child, neonate, and infant. So if you want to cover all these parameters, so the main definition is decrease in hemoglobin concentration below the reference range, as some of our colleagues were saying as per WHO criteria, below the reference range according to age, sex, and distribution. That's what I know about that.
Yes. Okay. So the next question which needs to be answered, that how can you classify anemia? Like what can be the ways of making different types of anemia? Yes, Tayyiba.
Sir, on the broader prospect, we can classify anemia on two categories. One is the etiological, based on the cause, and other is the morphological, according to the morphology of the RBCs.
Okay.
Now, talking about the etiological cause of anemia, they
Tayyiba,
are
there is
again
some.
subdivided into two
I think there is some problem in
classes.
your. There is some. Tayyiba, Tayyiba, there is some problem in your internet connection, I think.
Let me check.
Yes.
Okay, let me start it. Now, hello, can you hear me?
Yes. Yes.
Okay. So I was talking about the classification of anemia. So on the broader aspect, we can classify anemia on the two bases. One is the etiological, which is based on basically the cause of the anemia, and other is the morphological morphology of the RBCs. Now, talking about the etiological causes first, there are three again subtypes. One can be hemorrhagic anemia due to the blood loss. Other is the Hematopoietic Anemia. This is basically because of the inadequate production of RBCs. And third one is the Hemolytic Anemia. So there are some other the causes of hemorrhagic anemia can be acute or the chronic hemorrhagic, hemorrhage, trauma, the postpartum bleed, or in the case of the chronic as bleeding peptic ulcers or the hemorrhoidal bleeds. Now talking about the dyshematopoietic anemias, which is basically because of the inadequate production of RBCs. We can again classify into deficiency anemia of the nutrients, which is iron deficiency, vitamin B12 deficiency, or the folate deficiency. Again, it can be because of the aplastic anemia, in which all the cell lineage are decreased. Anemia of the chronic disease, also because of the any other autoimmune diseases, which is rheumatoid arthritis, or which can include the chronic renal failure as well. Now talking about the hemolytic anemia specifically, we can tell that this can be because of the genetic conditions or the acquired condition. The genetic conditions can be the hereditary spherocytosis, or the thalassemias, or the sickle cell anemias, or G6PD deficiency, and the acquired anemias.
Tayyaba, I will just stop you for a while and I will ask a counter question. You just labeled two ways. So I think I will just suggest you that you say that anemia can be classified or divided into many ways. Okay, rather than just making, because I will ask you a counter question. Where will you put? Because this is the thing which is more important for anesthesia, is whether the anemia is compensated or decompensated. Am I right? Because actually
Yes,
as anesthetists are not much related to the whatever the cause is, whatever the etiology is. At the end of the day, we are on the receiving end and we just have to deal with it. Okay. So you can the classification which you have chalked out, you will not be able to put where is compensated and decompensated. Am I right? So like I will
Yes,
just add into you, and for example, this because this question is a very, very broad question, am I right? Okay, so this you can like say so many things about it. So instead of making one or two or three, just say that it can be classified in many ways. Okay, so that will make yourself open. Okay, so this is one thing, because in table viva, it's least likely to be asked. Is it for two people? For the candidates, you will be asked in long case. Okay, and you will be able to, because when you will be labeling it and like compensated or decompensated in anemia, at the end of the day you are facing either of them. Okay, so this is just my suggestion.
yes,
Otherwise you are telling in the perfect way. And another thing, for example, how will you label sickle cell as only hemolytic? Is the only the problem in sickle cell anemia is only hemolysis or something else? Okay, so that's why I'm just telling you that you can say that there are so many ways to classify, either because of the loss, either because of problem in the production, or either problem in the early destruction. Okay,
hemolysis. Yes,
because of the problem in the hemoglobin synthesis, like there are some genetic defects. So I'm just telling you, it's not wrong. I'm not saying that you are telling in a wrong way, but I'm just telling you that you can make it even more open to the examiner. Okay, so as you have told, so we will go one by one to different places. So because if you say only in the shape, size of the RBC, this one RBC, so either it is microcytic or macrocytic. Okay, so if for example you will be telling about cause, so it can be iron deficiency or folic acid deficiency, or as you told about aplastic anemia, so it will be because of anything which is causing bone marrow suppression. Okay, so that will be leading to all the cell lines destruction. Or if you are talking about loss, so either it can be some
acute or chronic.
acute or chronic. Loss can be acute or loss can be chronic. Okay, it can be part of a chronic disease, as in like liver disease or renal disease. Okay, so there are so many ways. It's countless actually. Believe me, it's countless. Okay, so so if, for example, if I say that if you want to evaluate, or another question, that how the what can be the symptoms of if the patient is having anemia, okay, in the preoperative period, how the patient can present.
Sir, the patient can present as symptoms of palpitations.
Just a second. If anyone wants to add, he or she can raise the hand, and I will ask. I will give the chance. Okay. So what will be the symptoms of anemia, Tayyiba?
Sir, symptoms can be the palpitations, tachycardia, or the patient can look pale, jaundiced, and on the general physical examination, we can also look for clubbing, cyanosis, chylonychias, and other symptoms can be weakness, occasional dizziness. Patient also complains of tingling and numbness. It can be anorexia and palpitation, as I already told.
For history, I will give you a suggestion that you can say that there are some history points which are related to the actual presentation, and there will be some points which are related to ruling out the cause. Okay, so both of them will be in history. You understand my point?
Yes.
That there will be, and usually the symptoms are either because of compensation, what the body is trying to compensate, like the thing which we are saying, this palpitation. Okay, so palpitation is because how body is compensating to anemia.
So because there are several ways that a body basically tries to compensate for this anemia. One is the increase in the oxygen extraction ratio, that the tissues of the body increases the oxygen and extraction ratio of their demand, but the oxygen, for example, the skeletal muscles or the kidneys, but those organs that have already have the higher extraction ratios, they are unable just to compensate using this mechanism. For example, our brain and heart. The second compensatory mechanism which our body uses is that it increases the cardiac output. As anemia increases the viscosity and reduces the systemic vascular resistance, and in return of this,
Yes.
it increases the cardiac output. The third one is the basically on the cellular level, which is the oxygen delivery to the tissues, that body compensated by giving the oxygen to the tissues by converting the oxygen hemoglobin dissociation curve towards the right side, which is also known as the Bohr's effect. So these are three important compensatory mechanisms which our body tries to get through this anemia.
Okay. So you will try to find whether the because this is we have to be on the, again I'm repeating the word, business end. Okay. So you have to be meticulous whether your patient is compensated or decompensated. Okay. So when the patient will be decompensated, what will be the symptoms in you can pick? What will be the
Symptoms of failure? Symptoms of heart failure will be there. Yes.
On what else?
And patient and cyanosis, that the oxygen hemoglobin dissociation curve is no longer, delivering the oxygen to the tissues.
You open another chapter. Are there chances of cyanosis and anemia? Actually, sometimes if anemia is very severe, because what is the definition of cyanosis?
Cyanosis is the
cyanosis is increased deoxygenated hemoglobin more than 5 gram per dl, am I right?
Yeah.
So maybe in severe anemia, patient will not be cyanosed. Okay.
Yes.
Sir Zishan, can I add something in regarding this the symptoms of anemia?
Yes.
One is, sir, also difficulty in swelling, sir, dysphagia. Another are sir, symptoms of bleeding.
How difficulty in swallowing in anemia?
Sir, is difficulty because of esophageal web.
No.
Iron deficiency.
Yes.
Iron deficiency,
Okay. Fine. This can be a symptom. Fine.
And second one is bleeding from site or hemorrhagia.
Yes. Okay. There will be history of bleeding from any orifice or anything, and you did not tell about the drugs. You did not tell about any specific disease or yes.
Immunosuppressants or the antineoplastics.
Like I will give you the hint. Just think about it. That if you divide your symptoms in two parts, the sum of the symptoms related to the body response or the actual problem of anemia, and other questions or other history will be just to rule out the cause of anemia. Okay. So in this, if you will target like that, you will not miss anything. Okay. So like you just scan in your body, in your mind, is there any hereditary problem? You can ask this, is this anemia as in your history, in your family? If she is a female, you can ask about the menstrual history. So it will give you a hint. If the patient is having any other systemic disease, you can accordingly chalk it out. Okay. So Dr. Atik, please, can you tell some findings in the anything else remain left in the history related to? There can be history of NSAIDs. Okay, there can be history of taking like as we told, immunosuppressants. Okay, there can be some surgical history.
There can be history. There can be history of sir, malnourishment, sir. There is history of malnourishment, sir.
Yes. And for example, any surgery in which they have removed the part of the gut where there is absorption of the
Short
important
gut
nutrients.
syndrome.
What's that?
Short gut syndrome, sir. That is when
Okay,
the
short
ileal
gut
part
syndrome. I'm sorry. I'm sorry. I
Yes.
did not hear you, short gut. I thought you are telling some very refined syndrome. Okay. So some family history will be telling you something. The general symptoms will be telling you something.
Gynecological issue.
Gynecological history, ENT. Okay.
Abortions, pregnancies, multiple pregnancies,
Yes. Okay.
hysterectomy, ileal resection,
Yes.
any drugs, anti-leukemic drugs, DMRD,
Yes.
and steroid and antithyroid drugs as well.
Yes. Okay. So now move on to the examination. So what findings you can get in a patient with anemia? It should not be cyanosis, I suppose. Atik bhai, can you tell?
Yes, sir.
Yes, sir, there should be no cyanosis, only
No, you don't need to say there should not be. Don't make it yes or don't make it no.
the patient, first of all, the patient will look pale,
Okay.
and the patient would can be having chironecia, leukonychia.
Just a second. Just a second. Instead of jumping to the very refined words, chironecia and this and that, try to be very simple. What will you find in examination? Try to start from the vitals. Okay. What will be the vital signs like be in anemic patient?
Pulse, there will be palpitations. The pulse can be
not
increased.
Palpitation is not a sign. Palpitation is a symptom. Tachycardia.
Tachycardia.
Okay. Number two.
Number two is blood pressure can be low.
Blood pressure can be low. Okay. And number three, vital.
Three vital, sir. The patient respiratory system, respiratory rate can be increased.
So the patient will have tachycardia, tachypnea, and blood pressure is not actually, unless it is hypovolemic, maybe blood pressure will not be telling you anything, or it may be compensated. Okay. So then from here you move on.
So
where would you like to see the pallor?
The patient can be the patient looks pale, pale, and on examination in the hand, the patient have maybe clapping. The patient can be cyanosed. The patient can be cyanosed, sir. And there may be
listen, you don't need to mention cyanosis. You don't need to say that a patient can be cyanosed, because usually cyanosis has not much relationship with anemia. Don't I'm not saying that there will not be cyanosis. No need to mention, because usually in anemic patient you will not find cyanosis. This is my plea. Okay.
Okay, sir. Okay. Sir, there can be chironecia.
Okay.
And the patient can have leukonychia.
What is leukonychia?
And on
what is leukonychia?
Leukonychia, sir. I can't say the exact word, but it can be.
I think because of some fat. If I'm not, I don't know. But yes, okay, fine. Move on. What else?
Where is Rabia can and on examination on the face, especially on the tongue can be shiny and smooth, and the patient may be having pale face.
Pale face, pale conjunctiva. Tongue can be pale, but I think the more important thing is the palmar surface of the hand and the conjunctiva. Isn't that?
Okay. Yes, exactly, sir. Exactly.
And then when you told about chironecia or something, there can be some tremors, because sign of generalized weakness. Okay, and shortness of breath. When you told about tachypnea, you can tell shortness of breath as well. If according to the severity of anemia, according to the acuteness of anemia, if the patient is hypovolemic as well, then the blood pressure can be low and peripheries can be cold and clammy and sweaty. Okay, and you can tell some character of the pulse as well. That patient can have, if the patient is really hypovolemic, there will be
high bounding pulse.
From high bounding pulse to thready weak pulse according to the scenario. Okay, so when you are because you know we are just practicing at the moment. In the real time you can just chalk it out, but try to focus on, don't focus on difficult words, koilonychia and leukoonychia. If you forget koilonychia, maybe he will not fail you, but if you forget to mention about tachycardia, tachypnea, shortness of breath, he can fail you. Am I right?
Exactly,
so whenever you are telling anything about the examination, try to start from the vital signs. Okay, patient may be anxious, like general look of the patient. You can start from general look of the patient and then you can move forward. What finding you will find in the cardiovascular system? Very important thing. In anemia, chronic anemia, especially chronic anemia, not in acute anemia.
Sir, in the cardiovascular system, sir, we will having on
two of the things you have already told, that there will be tachycardia
and there will be systolic murmur, sir.
Yes, very good. Okay, so there can be signs, variable signs of any heart failure, but usually because of high cardiac output, you can find third or fourth heart sounds, or you can have what we say systolic murmur. Okay,
in the apical region.
Yes, what like generally systemic vascular resistance will be increased in chronic anemia and it will be decreased in acute anemia. Am I right? If it is acute anemia, then there will be vasoconstriction. Okay.
Exactly, sir. Exactly.
Just like in hypovolemic patient, what we face actually these is the things which we face practically. Okay. And if it is compensated chronic anemia, you will find the signs of, like you were saying, bounding pulse. Okay, the signs of high cardiac output. Any other sign you can pick? What about just GIT? Anything in the abdomen you can find?
There can be splenomegaly.
Very good. Hepatosplenomegaly according to the cause. Okay. What else?
And there can be, sir, there can be liver enlargement as well.
Okay.
It can
what
be,
else?
sir.
What else?
And it can there can be diffuse tenderness in the liver as well, sir.
Forget about it. One word is enough. Hepatosplenomegaly. That's enough, I think. Okay. Then what else? If like, let's try to see like this one.
Dysphagia.
Dysphagia. Okay. Yes.
Tongue, there should be a.
There will be tongue is smooth and shiny, sir, because of the atrophy of the papilla, of the villus papilla, sir.
In which condition this happens?
Iron deficiency anemia.
Okay. Okay. What is another thing which you can find if there is a cancer, or like which can be a prominent feature in
there may be lymphadenopathy, sir.
Lymphadenopathy, sir.
Lymphadenopathy. Okay, fine. What else? What about bone pains?
Exactly, sir.
Okay, bone pains. And what happens in like hereditary problems like sickle cell disease or thalassemia? What happens?
There's especially, sir, pain in the occlusive crisis when the patient is in anemia. The patient has having occlusive crisis, veno-occlusive crisis. Because
of fragility of the RBC and fragility of the hemoglobin, where sickling is occurring, sickling occurs, and it is causing infarct. Okay, so because of the infarcts, there is like
organ damage.
And organ damage, no pain. We are talking about pain. Okay, So the reason for pain in anemic patient, this sickle cell disease is like that. And other is the like any signs of this one, what is that called as? Increased because whenever patient is receiving blood transfusion, so there can be sign, actually we missed it in the history, there can be signs and symptoms related to blood transfusion.
Iron overload.
Iron overload in the form, in the thalassemia, what we call it?
No.
Thalassemic phases. Okay, so that is a mandibular protrusion, and this is mandibular or maxillary. I am just mixing it up.
Maxillary, sir.
Maxillary, sir.
Maxillary. Okay, so it can cause problem in the intubation. Okay, it can cause difficult intubation. Yes, Bilal, would you like to say something?
The discussion is over, and no one is around to add something. I just want to summarize.
Yes.
The basic concept of anemia and its presentation.
Yes, sure,
and its
sure.
implications.
Yes, Bilal, you can add.
So I hope that I am audible to everyone, right?
Yes.
Yeah, so basically anemia, as I told you guys earlier, that decrease in hemoglobin concentration below the age, below the reference range according to age, sex, and distribution. This is basic definition. And if you guys know the basic structure and components of hemoglobin, it's very easy to classify the types of anemia. I know in the house, most of the people have talked about each and everything, but if you go in a sequence wise, it presents the candidates in a better way. So would you mind to tell me that what are the components of hemoglobin? So I just want to make it bit interactive. I know all this stuff, but if what I believe that if I will keep talking and you know, I cannot grab the
Bilal, I'm sorry.
concentration of everyone for a long
yes.
time.
Yes,
Hello?
Bilal, can you be a little loud? Your voice is coming very low.
Okay, so I'm saying that if anyone, I appreciate that if most of the people get interactive with me, so that we can just make this topic very easy and clear, and I think then there will be no need to memorize this all classifications and this stuff. So anyone can enumerate the parts of hemoglobin, so that we can just proceed in our discussion.
Yes.
Assalamualaikum, sir. May I say?
Yeah. Sure, please.
Sir, blood is composed of plasma and
No.
Hemoglobin.
Excuse me.
Hemoglobin.
Wait, we are talking about hemoglobin. Forget about plasma. Forget about blood. Hemoglobin.
This is basically made up of.
Just a second.
One by one, please.
Yes. Yes, please. Rabia, continue, please. Tayyaba, if Rabia is not speaking, you can speak.
So basically, hemoglobin is made up of the 4 subunits of 2 alpha and 2 beta chains. I am talking about the adult hemoglobin.
Okay.
Okay, so simplify heme and globin. Okay, and globin, whatever you say the chains, alpha, gamma, beta. Okay, that's a globin part, right? So how about heme part? What's there in heme portion?
So heme contains iron.
Very good. And
RBCs.
and what else?
No, we are talking about HB, hemoglobin, Atik bhai.
We are talking about hemoglobin, sir. So globin and heme. globin is protein part, which are different chains, right? And heme is iron and 4 pyrrole rings, porphyrins. Maybe you guys can recall that, right?
Yes.
Okay, so if globin part is deficient, so in general, anemia, what happens? Either there is some problem with production, or there is excessive loss in the form of bleeding, occult bleed, or some heavy bleeding, or there is some hemolysis. And that is other deep discussion. Is it intravascular or extravascular? So if we say globin part is not being manufactured, so can you give example?
Thalassemia, sir.
Sure. Which one? Beta thalassemia, alpha thalassemia, right?
Yes, sir.
If we talk about there is some problem in the sequence of amino acids in globin part, what is your example?
Sickle cell.
Sickle cell
Yeah.
disease.
Sickle cell.
Yeah. So if we talk about iron metabolism, 2 broad categories, say something quickly.
Iron deficiency
Hemoglobin.
anemia.
Sorry?
Iron deficiency anemia.
Correct. And second one?
So
Sir,
methemoglobin.
anemia.
Methemoglobinemia, correct. What happens in methemoglobinemia? Methemoglobinemia is basically not anemia. We are talking about anemia, right? In methemoglobinemia, what happens? The ferrous form of hemoglobin goes to ferric form. That is a separate discussion. Okay, so I will give a clue regarding iron. What happens in anemia of chronic disease?
Iron deficiency anemia.
Some
Hemolytic
mecanoblastic anemia, vitamin B12 deficiency.
No. See, I am saying fan and you are saying tap. I am saying bike, you are saying car. I'm saying that what happens in anemia of chronic disease, and you are saying megaloblastic anemia.
There's decreased production of erythropoietin.
Okay, perfect.
There's also less red cell survival.
Where your body iron, extra iron is stored, in which form? Serum ferritin have yeah. So what happens in chronic disease, these inflammatory markers, interleukins and all this stuff, what they do, because these microbes and some pathological agents, they require iron for their growth. So body, as a compensatory mechanism, it stops the release of iron from iron stores in the form of ferritin. And anybody who has got some chronic disease, whatever the disease is, rheumatoid arthritis, or Sjogren's syndrome, or COPD, or asthma, or any autoimmune diseases. So release of iron from the stores, which is serum, that is ferritin, that is blocked. So that's why people develop anemia. And that's the reason that even the release from the stores is blocked and your intake of iron is fine. So in the chronic disease, picture can be dual. Either it can be microcytic or normocytic. Okay, so these is so broadly, if you divide hemoglobin into globin part, you already told what sort of things. And for the synthesis of heme, iron, we talk about already. And second cause can be that there are few things. Why? Because we have briefly discussed about the components of hemoglobin. So what is the role of this folic acid and vitamin B12 in the in development of anemia? Anyone knows? Should I tell you? Because I know we have short time, and I don't want to interrupt you guys for prolonged time.
Bilal, I think you can just.
Sir, I don't think it is in the scope of our Viva.
This is in the scope, Zishan. This is in the scope of our Viva. This will be a question.
Iron is
Listen.
required
Just a second. Let me clear this comment, please. Bilal, you just give me a second. Actually, Zishan, in the table, in the long case, examiner is just like having a power play of cricket. Okay, so you cannot say this is beyond the domain of our. They are asking things you will be surprised. They ask even about match test. They ask about ice pack test. They ask about the things which you have never done. Okay, they are asking you about what is the mechanism of retinopathy, what is the development of this is very important thing. Even, for example, forget about this thing. This, as an anesthetist, anemia is our selling point. Where daily whatever we are doing is revolving around anemia. So I think
no. If some gentleman thinks that it is out of scope, I have no offense, but a lot of people are talking about megaloblastic anemia.
Just a summary. Bilal.
So folic acid and vitamin B12 are involved in the pathogenesis of megaloblastic anemia, right? Yes. I'm very bad in keeping names, so I don't know who is considering that it is out of scope.
No problem.
We respect your opinion. No
Bilal,
offense.
just give few summarize words.
So what happens that these are the causes of macrocytic anemia. When we say macrocytic anemia, then mean corpuscular volume is more than 100. So basically, this folic acid and vitamin B12 is required for the maturation of nucleus. RBCs are nucleated or anucleated?
Anucleated, sir.
Yeah, so if there is deficiency of folic acid or vitamin B12, there is no maturation of RBCs. There is no maturation of nucleus in the RBCs, and the bone marrow throw these red cells with nucleus and they look bigger. Okay, so that's the reason that these two vitamin deficiencies results in megaloblastic anemia. And there are so many causes about that, which I will agree with you guys that is out of your scope.
Yes.
And third part is hemolytic anemia. So mainly, then there is a long discussion about intravascular hemolysis, extravascular hemolysis, and due to mechanical hemolysis. So mainly, if there is some autoantibodies against RBCs, they will destroy the RBCs. So we will say hemolytic anemia. And mainly, you must know about the Coombs test, direct and indirect, which is usually indicated even in general evaluation of anemia. They do LDH, Coombs test, indirect Coombs test. These are the main clinical indicators to diagnose hemolytic anemia, and especially if someone is having valve replacement. If you see some patient who has got mitral valve replacement or aortic valve replacement or dual valve replacement, and valve is metallic valve, they develop anemia. Why? Because when the RBCs pass through these metallic valves, they get lysed. Okay. So that is another reason for anemia. And most important is in male, if somebody is more than 55 years old and he's developing anemia, the main focus goes towards gut, because CA colon or some malignancy, and in case of females, menorrhagia and this stuff. So I think for an anesthetic perspective point of, because now a lot of people are saying thalassemic phases. So somebody is saying maxillary prominence, somebody is saying mandibular prominence. It's not thalassemic phase. Thalassemic phase is frontal bossing. Your frontal bone, your forehead is, quite prominent, and depressed nasal bridge. Okay, and a lot of people are saying beefy tongue in iron deficiency. Are you sure this is in iron deficiency? Beefy tongue, shiny tongue. In which anemia you see this finding?
B12. Bilal, is somebody has? I don't know.
It's B12. It's B12. It's B12. Okay, and where vitamin B12 is absorbed in the gut, terminal ileum. So if someone is having Crohn disease or ulcerative colitis, they will be having this megaloblastic anemia, where iron is absorbed in the gut, jejunum. So if somebody is having, as one of our colleagues was saying, short gut syndrome, so they are more prone to dual iron deficiency. So if you talk about, you have told most of the sign and symptoms. So, selection of words is very important. Rather to say low blood pressure, if you say hypotension, that is more appropriate. Rather to say increased respiratory rate, if you say tachypnea, that is more appropriate. And one of our colleagues was saying bounding pulse. What do you mean by bounding pulse? If your pulse pressure narrows, pulse will be bounding, or it widens, then pulse will be bounding.
I guess narrow, sir.
Okay. When narrow pulse, have you seen narrow pulse? If someone has got 2 liter blood loss, I guess the patient will be having a narrow pulse. Right? What do you mean by narrow pulse? It means that pulse pressure is narrow. What is pulse pressure?
Difference between diastole and systole?
Diastole and systole? Can you review your statement? What are you saying? Wake up, please.
Systole and diastole.
Between.
No, systole, that's systolic blood pressure minus
Systolic and
diastolic.
blood pressure.
Systolic blood pressure and diastolic blood pressure.
Yeah, so always look before what you are gonna say, systole and diastole. And the bounding pulse means widened pulse pressure. Have you palpated pulse of any septic patient ever in your clinical experience?
Yes, sir.
Or let's say, of course, in your center, people are placing epidurals for post-op analgesia, right?
Yes, sir.
Yes, sir.
What happened? So when someone is having epidural analgesia, let's say for laparotomy and post-op, you just palpate the dorsalis pedis. It's just like pushing your hand away from the surface of dorsum, because it's bounding. Bounding pulse means widened pulse pressure. It means that systolic pulse, diastolic is really, really low. And nobody. Yeah, whatever the reason, this is a long discussion. And second, nobody has spoken about ischemia. If you take EKG of some anemic patient, there can be ischemia, right?
Myocardial oxygen, because of a difference in myocardial
disturbance of demand and flow.
Okay, so what are the factors for demand and what are the factors for supply of myocardium?
Yes, Tayyaba?
I know a lot of people think that it is out of scope, but no. This discussion is only for brainstorming. Believe me.
I tell you, I will interrupt Bilal. My long case was an anemic patient with CA esophagus for esophagectomy. Okay, and their main focus was how anemia occurs. What is difference between compensated versus decompensated, okay, and some of the things which you are discussing, okay. So please tell what are the factors for
The
myocardial.
factors of demand are
The
heart
factors,
rate, wall tension, in which preload and afterload, and contractility, and factor of supply are hemoglobin, oxygen content, and coronary perfusion pressure, in which left ventricular and diastolic pressure and aortic diastolic pressure, and also heart rate.
Now, tell me what are main factor for demand and tell me what are main factor for supply. Don't mix it up.
so heart rate is basically included in both demand and supply. So demand, in demand we can say heart
Okay, fine,
rate.
fine. Heart rate is finished. Now jump to next. We agree and yeah.
The wall tension, which basically comprise of the preload and afterload. This also
What do you mean by wall
determines the
tension?
demand.
How wall tension increases? Don't say preload, afterload. That is a different discussion. What is wall tension? How wall tension increases? I'm a normal person and I don't have any comorbs. My myocardium is having increased wall tension, or if somebody who is having hypertension since last 20 years.
So when afterload increases, wall tension.
You are talking about again. No. Afterload, you give phenylephrine to somebody and SVR goes up. You say wall tension increases. What is your opinion about left ventricle hypertrophy? If somebody is having hypertrophy, ventricle wall tension increased or not?
Yes, sir.
Yeah. And what next? Keep talking, keep saying.
So contractility of the heart also determines the demand. The greater the contractility, the greater the demand. The basal metabolic requirement of the heart also determines basal metabolic requirements of the heart. Also determines
basal
the demand.
Metabolic rate. Okay. Okay. So what are conditions when the BMR goes up?
Fever, sepsis.
When yeah. Hyperthyroid.
Hyperthyroid.
Yeah. Thyroid storm, malignant hyperthermia.
And what else? What other high output state? Your anemia also, right? When you are anemic, you are in high output state, right?
Yes, sir.
If somebody is having a very large AV fistula, then it's high output state or no?
The AV fistula.
Yeah. Okay.
Yes, sir, it
leave
is
it.
high output.
Leave it.
High output.
Yeah.
Because the
So for demand, can someone else repeat it again so that it keeps a permanent impression in your brains? So one, our colleague told heart rate. What next?
Sir, wall tension.
What next?
Contractility. And
correct. And what next?
Overload, like increase of preload or increase of stroke volume and diastolic volume. It also increase the demand of
that is a factor of supply.
Yeah. So how about supply? Let's say you have someone in his house has a water supply, and that is, let's say, half a meter wide, and someone is having a water supply that is only few inches wide. So which drain gonna drain in a more appropriate way?
The one with the high diameter?
Yeah. So if someone is having disease coronaries, so it will affect supply or demand?
Supply.
Okay. So if someone is having installed drainage system and they placed a motor pump in their top floor to just throw a good volume of water out of taps, and someone is just using gravity mechanism. So which fellow is gonna have better output via their taps? The one with
The one with the
water
artificial
pump?
motor. Yes.
Okay, so where this is implicated? You were talking about coronary perfusion pressure, right?
Yes, sir.
What is coronary perfusion pressure?
It is difference
It's
of
the
aortic
difference between
diastolic
the
pressure
diastolic.
and left ventricle and diastolic pressure.
Huh? Come again, please.
The difference of aortic diastolic
So it's
pressure
the difference
and
between aortic.
Do you know
yes, Taiba, you
actually?
please carry on.
Huh? One by one. If
So it's the
someone wants to
difference
say,
between the.
Yes, speak out, please. Finish. Don't stop.
So it's the difference between the aortic diastolic blood pressure and the ventricular end diastolic pressure.
okay, so what is aortic diastolic? Why we are saying diastolic? We are during systole there are high pressure, and we are talking about diastolic.
Because myocardium perfuses in the diastole.
Okay, so what is normal aortic diastolic pressure and normal left and ventricle and diastolic pressure?
Don't know.
What is normal blood pressure? What is normal blood pressure?
120 over 80.
120. I
Then
think
we can
aortic
get
diastolic pressure is
diastolic.
120/80.
See, you. What is your name?
Taiba.
Okay, Dr. Taiba, you are saying diastolic pressure, and now you are answering that normal aortic diastolic pressure is 120/80. So which sort of evaluation you are expecting after this sort of statement? We are saying diastolic, and you are saying 120/80. The answer is 80. If you want to specify, but I am asking what is normal pressure, then say 120/80. Then don't mix up your statements. You are telling a lot of things correct, but you are not telling in a appropriate way. Please work on it. So normal diastolic pressure in aorta is 80, and normal diastolic pressure in left ventricle is 8. So can somebody tell what is normal coronary perfusion pressure?
So 25.
What is your name?
Dr. Atik.
अतीक भाई, अगर आप 80 में से 8 माइनस करें तो 25 जवाब आता है.
No. Bilal, everyone is understanding only English, so it will be range.
Okay. So if you subtract 80 minus 8, answer is 25.
You see, you people have today found a difficult examiner, am I right? So
72.
it's just practice, okay? Okay,
80 minus 8, what is
I
answer?
just
72 ml.
Bilal, just give me a second.
72 millimeter mark.
Tayyaba, I hope you understand. You see, this is the tuning. This is the real, because you know you can learn, you can read anything in the books, okay? But this real time tough pressure will make you well equipped in the exam, okay? So don't. I hope nobody will mind, because we are here for the betterment. Okay, so please don't mind.
Not at all, sir. Not
Yes.
at all.
So 80 minus 8 is 72. That is coronary perfusion pressure. Okay, if someone is having left ventricular dysfunction, of course coronary perfusion pressure going to drop, and they're gonna be drop in supply to myocardium. So we talk about so far 3 factor of supply. One is heart rate. What was second one? Diameter of coronaries. What is third one?
The coronary perfusion pressure.
Yeah, pressure which is perfusing coronaries. And fourth one is
The heart rate, which
carrier
is
on
common
which,
in both.
no. Listen to me.
Hemoglobin.
Fourth one, yes. Fourth one is the hemoglobin on which oxygen is traveling throughout the body. So if you talk about anemia, I guarantee you they are gonna ask you about supply and demand of myocardium. And your whole patient management is going to be on the demand and supply of myocardium. So if you have concept about it, you are not going to forget it. But if you are just trying to memorize it by heart, and you are just repeating it 1,000 times, and maybe you are able to produce in your exam, and your exam will be passed. But if you want to have a long-term impression on your brains, you have to think in this way. And very commonly asked question regarding anemia, they talk a lot about transfusion trigger, because nowadays most of the clinicians are against blood transfusion because this is similar like an organ transplant. So if patient is normal, healthy, what will be your transfusion trigger? In other terms, I'm asking at what level you will transfuse that patient.
Transfusion is
There are
based
10.
different factors.
No.
There are 10.
No.
The normal healthy patient, if hemoglobin is less than 70 gram per liter, then we will consider
Yeah,
as a
7. Yeah.
7.
But if someone is having ischemic heart disease or other factors, so they say
9.
keep it between
9
9 and
to
10.
10.
Yeah.
Yes.
Yeah. So that's more than enough. Okay. And rest all these signs, symptoms, this, that, it can be read from any book, but I have seen a few cases. I had worked as a medical officer in cardiology also, and I have seen a lot of patients who comes with ST elevation MI due to severe anemia, and when they are investigated, they don't have any risk factor, no smoking, no hypertension, no diabetes, no dyslipidemia, but when you look at their CBC, hemoglobin is 4 or 5.
Okay,
So
Bilal,
it's very important.
I will ask you to explain this Coombs test. Okay, just in a very simple way. What is the difference between direct and indirect Coombs test? Okay.
Yeah. So
because I
direct
have
Coombs
read
test
so many
is
times and I always forget. Yes.
okay. So Coombs test is basically they search that is there any auto antibodies attached to RBC's surface. Okay. So if someone is already having antibodies attached to their surface, okay, so in Coombs test they just add anti-sera, and if hemolysis is observed, it means direct Coombs test is positive and patient is having autoimmune hemolytic anemia. But in indirect Coombs test, what they do, they take RBCs and they mix RBCs with autoantibodies, and then they add anti-sera. And if hemolysis occurs again, that is called indirect Coombs test. And indirect Coombs test practical implication is cross-matching. Is it clear?
Bilal, just please repeat again.
Let's say someone has got some autoimmune disease and he is producing antibodies against his RBCs. Okay. So those antibodies are attached to the RBC's surface. Okay. When those RBCs pass through reticuloendothelial cells, like spleen, Kupffer cells of liver. So your helper T cells, lymphocytes, they recognize, oh, there is some problem with this cell. We don't know these surface. Its face look like a different. So they attack on that RBC. Okay.
Okay.
So hemolysis occurs, but in laboratory there are no, protective cell. There is no helper T cell or lymphocytes or T cells or B cells. Okay. So there are different anti-sera available.
Okay.
So they take sample from the patient and they add anti-sera.
Okay.
Okay. And if hemolysis occur, they say this is direct Coombs test.
Direct Coombs. And if I remember, this is to check the antigen. Am I right?
This is to check the antigen or autoantibodies that are already attached to RBC surface.
Okay.
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 But what they do in cross matching, they take recipient's serum.
Yes.
And they take donors RBC.
RBC.
Okay. They mix them.
So if there is antibodies in the
if
recipient,
there are antibodies in recipient serum other than A, B, O, that K antigen, L antigen, Defi antigen, this stuff, right? So what happens? Those antigens get fixed to the RBC surface, and then they add anti-sera. So this is indirect Coombs test, because they create such situation where antigens are attached to RBC surface, and then they give anti-sera to observe hemolysis.
Okay, so I hope you are.
Is it clear now?
Everyone is clear. Yes. This question can be asked during the pathology part of our long case. Okay, these are the questions which they can ask. So you should have a clear concept. Okay, and the myocardial oxygen demand supply ratio, believe me, it is the bread and butter of anesthetist.
So if any one of you can repeat demand and supply one more time, and then I can sign off.
Asim bhai, you just please do it. Asim, Dr. Asim Arif, please. If Dr. Asim is not there, Atik bhai, would you like to say?
Yes, sir. Yes, sir. Sorry, my mic was mute. Sorry. Okay, so there is supply and demand. Okay, so supply, there is heart rate and coronary perfusion pressure and arterial oxygen content with coronary vessel diameter.
Yeah,
this for,
so simple. Perfect. Yeah, perfect. Yeah.
And for the demand, there is again there is heart rate with basal metabolic requirements and wall tension.
That is different. Dr. Asim, that is different. Basal metabolic rate is different. Yeah, for demand.
Okay.
Heart rate. Okay. Second is basal metabolic rate, and what else?
Wall tension and contractility.
Yeah. So simple.
Okay. Okay. Anyone wants to ask any question up till now?
Yeah, so I need to go somewhere. If anyone has any question regarding anemia, I can answer, or I will try to answer. If I don't know, of course, I will apologize for that, because I need to go somewhere.
Okay, Bilal, thanks a lot for your elaborated discussion. And
no problem. It's my pleasure.
Give my love to Zarun, okay?
Yeah, sure. Thank you very much. Thank you.
Thank you, sir.
Bye.
Okay, so I will just try to continue from here on. So up till now, we just try to see what are the effects of anemia, okay? And the focused one, which are related to like anesthesia in the form of myocardial oxygen demand supply ratio. This is one thing. And the other thing, we just discuss how to like evaluate, okay? And some of the causes Okay, so if we just say talk something about sickle cell disease individually. Okay, so what is sickle cell disease? Who would like to just raise the hand and I will ask, what is sickle cell disease? Okay, Tayyaba, what is sickle cell disease?
Sir, first of all, this is a form of anemia or a type of anemia, which results due to the, or you can say this is a hemoglobinopathy, which is a structural defect in the hemoglobin structure, resulting in the formation of unstable hemoglobin, which is known as the HbS. And this hemoglobin S basically do not tolerate the stress and got sickle.
Okay, this is finished. Perfect. Okay, so Atiq bhai, tell me what will be the effects of this? Like Tayyaba told that the hemoglobin is not stable, okay, and it is unable to tolerate the stress. So what will be the effects of this stress related destruction or problem of hemoglobin? Yes, Atiq bhai.
Due to certain effect would be due to sickling, and in the deoxygenated state there will be sickling, and the sickling will causing membrane damage, red cell membrane damage, resulting in
no, sorry, I repeat my question. I told as she told that there is the hemoglobin which is formed is not stable. Am I right? Okay. So in the other patient, if we are just putting hammer, nothing is happening. But even if we are just tapping, hemoglobin is finishing. This is the example. Okay. So now what will be the effect because of this sickling?
You want to say that what would
what
be
are the clinical, what are the business end? Like what? Just a second, Rabia, I will ask you. Yes.
Okay, sir, there will be a painful crisis.
Very good. This is one thing.
The second one is that can be acute chest syndrome.
Okay, though because of any infarcts.
Yes, third one is that there can be neurological damage like CVA. And
this is again because of infarction, because you see, I just want you to categorize it. One problems will be related to the pain anywhere. Okay, bone pains, joint pains. Okay, so this is pain is one thing, and second thing is because of infarcts anywhere.
Anywhere, sir.
Infarct in the brain will cause CVA. Infarct in the abdomen will cause severe pain. It's like even it can cause in pediatric patient with sickle cell disease.
It can cause even stimulatus as well, and it can because of.
So these are two things related to pain. There will be something if there is so much pain. So this will also be a consequence of the pain. What will be that? Opioid addiction. Okay.
Opioid addiction.
So this is related to opioid addiction. And the painful crisis, what will be the different painful crisis, or what will be the effects of different infarcts? One you told CVA, one you told acute chest syndrome. What else?
Acute acute chest syndrome. Veno-occlusive crisis like priapism, sir.
Okay.
And vascular necrosis because of this sickling.
What about limbs? Limb ischemic pain.
Limb ischemia and
limb ischemia. Okay.
Yes, limb ischemia and abdominal pain as because of ischemia as well, sir.
Okay, so actually there are you can remember with the pneumonic VASH, vaso-occlusive crisis, aplastic crisis, sequestrational crisis, and hemolytic crisis. Okay.
Okay. Sir.
So you can just use this mnemonic. So okay, fine. So
and because of these sequestration, there can be a secondary infection like stimulatus as well, sir.
What did you say?
Stimulatus because of this.
What's that? Please, can you repeat again? What infection?
Sir, stimulatus, sir.
Osteomyelitis. I'm sorry. I was not able to understand. Osteomyelitis. Okay, fine. Fine. Okay. So Rabia, my next question to you, that what are the factors which can precipitate this sickle cell crisis? What are the factors?
Yes, the factors precipitating sickle cell disease or sickling are hypoxia, hypovolemia, pain, hypothermia, and any acidosis, hypercarbia.
Okay.
These
Stasis.
are the
Stasis.
Stasis due to any tourniquet.
Tourniquet or venous stasis. Okay. And okay, hypothermia, hypovolemia,
hypoxia,
hypoxia.
dehydration.
Okay, so so this is how
Any stressor like
so
pregnancy,
in a
infection.
patient with the sickle cell disease, what perioperative care would you do?
Sir, first of all, perioperative care would be start from with brief history, examination, and investigation. I would look for the duration, severity, and organ damage of the disease, and I would look for the level of hemoglobin S and in the in patient.
Very good.
And
Actually, that's what I wanted to listen from you. How much hemoglobin S level should be there?
Sir, that should be less than 30 in non-cardiac surgery and less than 5% in cardiac surgery.
Okay. And would you like to increase the hemoglobin to would you like to transfuse blood to increase the hemoglobin or no?
Sir, that is on the basis of risk versus benefit. If I would look target,
what will be your target?
Sir, my target would be to have hematocrit 30%, and sir, and also I would look.
What will be the problem if you increase it?
Sir, it can increase the viscosity of blood and stasis, and that can lead to sickling.
It will increase the sickling. Okay, it can increase the sickling. Actually, it will increase the chances of having infarctions and vaso-occlusive crisis. Okay, you don't want to over transfuse, and actually because these patients, this is one reason, and another reason is that these patients usually are having compensation. Okay,
yes, sir.
So they don't need too high hemoglobin.
Sir, a transfusion would be on the basis of risk versus benefit and risk of surgery. Either it is low risk, intermediate, or high risk surgery. For low risk surgery, we would not transfuse. We can go with without transfusing and
yes. All this, would you like to interact with some doctor like Tayyaba mentioned in the chat box? Hematologist. Your voice is not coming clearly, Rabia.
So we will discuss with the hematology department about the transfusion and about the level of hemoglobin for the surgery, and according to discussion will carry on.
Okay, so
but the level should be, sir, like it should be as the Dr. Rabia said, it should be for intermediate surgery, it should be 9 to 11 gram per deciliter, and it should for major surgery it should be from 9 to 11 again, but the level should be less than 30%, sir. 30% of the hematocrit.
So that's what, same thing. Okay, so these are the things which they can ask you about sickle cell disease. Okay, if they want to ask you too much details, they will give you a scenario, a patient with sickle cell disease undergoing some surgery. So you have to again scanning what sort of surgery is it, high risk or intermediate risk or low risk, and then you will be saying that I will evaluate the status of the patient, whether the patient is having sickle cell disease or sickle cell trait, what investigation you will be doing, hemoglobin S level, hemoglobin electrophoresis, sickle dex test, okay, and any sign of hemolysis. So you can do tests for hemolysis.
Somebody has written, sir, someone has written 30 to 40%. It's not 30 to 40%. It should be less than 30%.
No, it is 30%. just correct it, Mr. M. What's your? It's 30%. Okay, not too much. So this is all about sickle cell disease. Usually they can ask you these questions. It looks very like apparently it looks that what's a sort of, because if you are reading it from a complicated book like problem oriented, they will be telling you how to manage acute chest syndrome, what are the findings of acute chest syndrome. Actually, this will be you just have to say the default things. There is nothing specific. You will be treating it as any chest infection. You will be treating it as you can say like ARDS, lung protective strategies or whatever. So there is no need to waste your time too much, because it will be only part of the question, not the whole of the question. Okay. So another question, Asim bhai, how can you reduce the transfusion in a patient with anemia? What are the things which you can do to reduce the chances of anemia, reduce the chances of transfusion? Asim bhai, would you like to tell?
Yes, sir. So for reducing the chances in the pre-operative, you want to be in the perioperative period. Yes.
Okay.
The question, can I get my question back?
Yes. You see, listen. If you want to avoid the blood transfusion, it will be starting from the pre-operative. So even if they have not told you that you want intraoperative, so you don't have to jump directly to intraoperative. Okay. You have definitely have to start with the pre-operative.
So pre-operative, we will again we'll go from the history and examination and lab investigation. And if there is anemia, we have to do this full blood count. We'll see what is the status of hemoglobin.
Only full blood count or anything else?
We'll see the iron also, TIBC, total iron binding capacity, and all the things.
Even before that, peripheral blood smear. Okay, peripheral blood smear. This is one thing. And then chalking out the reason. Like you can finish your answer in one word, that if there is any finding, so you will be probing out or you will be trying to find out the cause of anemia. Okay.
Okay.
Then what else?
So
if there is anemia,
in the history we can
what options you will have to treat the anemia?
Pre-operative, we can do this pre-operative normal hemodilution.
No.
Patient.
No. Patient is anemic. So what options you will have?
Okay, for this patient, anemic patient, we'll see what is the hemoglobin level and how patient have a symptoms of this. How severe anemia is.
Just try to answer accurately. You are again going to the same answer which you have told already. Now, what are the different options you will have to treat the anemia? Usually,
we can sort out what is the cause of anemia, and if there is iron deficiency, we can start iron supplement for this patient.
Okay.
And
what are the different options? They will ask you in the same way which I am telling you. The question will be, what are the different ways to give iron and how much time you need?
We can give oral and IV. For oral, there is some complication for oral iron supplements. And for IV, this should be in a monitoring environment we have to give this patient. And we can give erythropoietin also for this patient if the patient is CKD or on hemodialysis or something like that.
Okay, so you just have to if someone asks you this question, what options you have to treat anemia, starting from the cause, and then accordingly the common things which are being used is to replace the nutrient. If it is nutritional deficiency, vitamin B12 or folic acid or iron in the form of oral or IV. Oral iron will have some digestive tract problems and problem related to absorption, and IV iron can cause even anaphylaxis or hemolytic reaction. Okay, so this will finish your job. Okay, and it will take at least 4 to 6 weeks to manage it in that way. Okay. IV iron will have relatively less time, but oral iron at least this say. So you can only do this thing if there is time permitted for that surgery. Otherwise, if the surgery is urgent or surgery you cannot delay, then you will have no other option than to transfuse the blood. Okay. So this is one thing, treating the anemia. And if, for example, if there is any decompensation, you will treat that one as well. If there is cardiac failure, you will treat accordingly. If there is a respiratory problem, you will treat accordingly. So this will be, and this is for increasing the hemoglobin. What else you can do in the preoperative period?
For anemic patient, you mean?
Yes.
Okay.
Anemic patient or a patient in which there is bleeding is suspected. So there can be some medicines which you would like to stop.
Yes, we can stop this anticoagulants, or patient is on like antiplatelet agents.
The better word will be to manage anticoagulant or antiplatelet according to the clinical situation. Okay.
Clinical situation. Okay.
If you say stop, patient will have something. Okay. You cannot use the word stop.
We can do this. Yeah, we can take suggestion from the hematologist or cardiology.
Yes. Yes.
To do bridging.
According to the situation, you have to outweigh two things: risk of thrombosis versus risk of bleeding. Okay. According to, if the risk of thrombosis is more than risk of bleeding, you have to give the bridging. Okay. If risk of bleeding is more than risk of thrombosis, or you cannot like you have to think, and what will be the consequence of usually if, for example, you stop it, or you so what can be the problem if you stop any anticoagulant or antiplatelet? What can occur?
There will be thromboembolism, or if there is a valve replacement, or there is a stent, especially drug-eluting, so there will be thrombosis on this.
Yes. So this is the reason why you are doing this. Okay. So this is one thing. Then would you like to discuss something with the surgeon?
Yes, minimally invasive techniques. I think we can use it.
Minimal invasive technique. Okay. What in the like from the anesthesia side, what are the options you can do?
We have anesthetic techniques and pharmacological management.
Okay.
With the anesthesia technique, we can do this regional techniques. It will help for
you can use the word multimodal analgesia, including some regional anesthesia to minimize the stress response. Okay, this is one thing. Number one. Number two.
And we can avoid intraoperatively hypothermia and acidosis, hypocalcemia. These all factors are involved.
Number two, fine. Then what else?
Then we can go for the pharmacological management.
No,
like
before that, there are a number of things. What about tourniquet? Use of tourniquet.
Yes, tourniquet. Yes.
What about positional strategies to avoid stasis? Like you will try to elevate the place where the surgery is occurring. Okay, like if you are, for example, you are having a surgery of ENT, and now the surgeon use the bleeding. You can just raise the head.
Hypotensive.
When you are doing this thing, what risk you are increasing?
For hypotensive anesthesia.
No. If you are air embolism, okay?
There is embolism. Yes.
Air embolism. This is one thing, and the other thing is that this one, if it is in combination with hypotensive anesthesia, in head-up position, cerebral perfusion pressure can be decreased. So if you are managing giving hypotensive anesthesia, that's why it is mandatory to have invasive monitoring. And would you like to change some way to monitor the invasive blood pressure in this patient? Would you like to do something specifically in a patient in which you have made the head side up? You will know
the transducer level, the transducer.
Transducer level you will zero it at the level of angle
Tragus.
of tragus, okay? Because this will just indirectly give you an idea of cerebral perfusion, okay? So this is very important thing. Whenever you are doing this, you can tell at that time that when we are doing this, this can happen, okay? So then you have to tell cell salvage, okay? Then if it is permitted, because this question is very important, because you have to tell this thing in different way. One option will be how to reduce blood transfusion, okay? One reason will be like if, for example, a patient is already anemic, in that patient you will not say normal hemodilution, but all other patients you can say hemodilution, normovolemic hemodilution or hypervolemic hemodilution, okay? You can do either hypervolemic hemodilution or normovolemic hemodilution. You know difference about hypervolemic and normovolemic hemodilution?
So for pre-operative, like autologous donation, this is the normovolemic that we are manage the surgery like 4 to 5 weeks before, and we'll take 3 to 4 units of blood.
No, that is not hemodilution. That is not the intraoperative hemodilution. You are right. You can keep his patient if there is rare blood group, or if you don't want to transfuse anyone else's blood, you just want to have the homologous blood, okay? So you can do this thing. But normovolemic hemodilution is that you remove 1 pint of blood, for example, and you replace it with equal amount of colloid or 3 to 4 times of crystallite, in addition to correcting the dehydration. That is normovolemic hemodilution. And hypervolemic.
But this is intra.
Yes, and hypervolemic hemodilution is that in addition to correcting the dehydration, you give extra volume. That is before the bleeding starts, the surgical stimulus. Before that, according to the patient condition, patient circulation system, you can do this thing. Okay. So like use of tourniquet, and then another thing is cell salvage. Okay, you can do cell salvage, use cell salvage, and the contraindications or precautions will be in case of amniotic fluid in obstetric patient, in case of fecal in the surgical area, fecal matter, and in case of even malignancy, there can be like there should be use of filter. Okay, so this is the concept. And then the thing which you were telling quite early, pharmacology. Okay, so pharmacology will be coming when all these things are, and you are having the hypotensive anesthesia, you are having the like avoiding the stress factor, you are trying to have the whatever reduction in the stress you can. Okay, so
intraoperatively, I want to add some points.
Yes,
sir,
your voice is coming from other planet.
Sir, now I'm clear?
Yes.
Sir, the technique to decrease the venous oozing should be done by decreasing and avoiding increase in intrathoracic pressure, avoiding hypercapnia, avoiding hypothermia and acidosis, and also the balloon ligation of arteries, and use of topical hemostatic agent like fibrin glues can be used intraoperatively. And
yes,
there are some modalities like ultrasonic equipments, QESA and lasers are being used. And
what about if you are talking so advanced things, what are perfluorocarbons?
Yes, sir, they can also be used.
I have never seen it. I don't know what is it, but this is also written in the list.
They are written in book, yes, sir. Sir, other things are pharmacological, which are tanzamine, aproptin, and desmopressin can be used. And
okay, so yes. So anyone wants to add anything?
And sir, post-operatively, apart from the things you have mentioned, our discussion again with the hematologist, less blood test, in specifically anemic patients, and again transamin, erythropoietin, and preference of fresh blood. In,
Yes. Yes, Tayyaba, would you like to add something?
No, sir, I think you have told enough. But in acute hypervolemic hemodilution, just be careful about the status and the cardiac
Fluid
status of the
status, yes.
patient.
Yes, I have
Yes,
told.
because
Yes,
yes.
yes, Bilal.
And
Yes, Bilal, would you like to say something?
Yeah, yeah, few points. What is hypotensive anesthesia? What is mechanism of action of this transamine? What are different regimes people are using, especially in the orthopedic surgeries? And how about the Salcevo? If you use Salcevo blood, what are your considerations? And how much hematocrit it gives back to body if you're transfusing the blood once the Salcevo gives you blood? This is MCQ, right?
Yes, Tayyaba. Or anyone wants to tell.
What is hypotensive anesthesia?
Sir, hypotensive anesthesia is a technique of deliberate lowering of blood pressure to decrease blood loss, but maintaining the perfusion of the vital organs.
Which one? Which organs?
Heart, brain, and kidney.
Okay, perfect. And how this transamine acts? Yeah, aminocaproic acid or tranexamic acid.
so they are basically the antifibrinolytics.
Yeah, we know. Yeah. What is mechanism? I'm saying what is mechanism of action? You are telling their other name. You are just broadly telling the class name. I'm saying what is mechanism of action?
Sir, transamine inhibits
How it stops bleeding, right? Transamine stops bleeding or it causes more bleeding?
Actually, it's stabilize the primary bond, means stabilize the bond between platelet and the fibrin.
It is
stabilizing agents.
stop altering the plasminogen to plasmine. That's why we can maintain plasminogen to plasmine. Stop altering the plasminogen to plasmine.
So this is actually TPAI inhibitor, tissue plasminogen activator. Yeah. So this is a simple sentence, and then examiner will be quiet, and he will get to he will proceed to next question. So this is TPAI inhibitor. So some people give a bolus, maybe 10 milligram per kilo stat, and they run infusion like 4 to 5 milligram per kg per hour throughout the surgeries. And of course, there are different departmental protocols, and they have already momentum of understanding that we are using this drug and in this regime. And Dr. Zishan was telling that in hypothermia, there is more bleed. What is mechanism of action for that? What happens? Why patient keeps bleeding if they are hypothermic?
Yes, Atik bhai, would you like to tell?
First of all, all coagulatory factors, they work at the temperature of 37, and they are efficient below this temperature. Second is the function of the platelet also decreases with the temperature. There is less.
So there is reversible platelet inhibition. So when patient is hypothermic, platelets stop working. Once you rewarm the patient, platelet regains their function. So that's the main mechanism. Okay. And even in the Viva, they may ask you what is temperature, what is hypothermia, what is mild hypothermia, what is moderate, what is severe, so what is temperature. these discussions get prolonged. Once you say something, they will say, okay, what is this? What is this? What is this? And these are not out of scope, believe me.
Bilal, actually, in Pakistan, most people are not familiar with the transanemic infusion, okay? Because usually most of the people, they are accustomed to give a bolus by advised by the obstetrician, okay? So,
even orthopedic surgery, they do it.
Yes,
in orthopedics, they do it.
Yes.
In hip surgery, in knee joint surgery, they do it.
Yes, actually, that's what I'm telling. That actually the effect is better if you are giving in an infusion. And this is one thing. And actually, there are some complications which can occur with the transanemic acid as well, in the form of microthrombi formation, and it can create some problems in case of patient at risk. Okay, so if the patient is at risk of some embolism, actually you have to be cautious. Okay.
So what are risk factor for this embolism? Or hypercoagulability, intraoperative, postoperative?
Like any obesity or anything like that.
Like cancer, like prolonged surgery.
Yes.
Like immobility, like recent OCP use.
Yes.
Right?
Yes. So you have to be careful. And
dehydration.
Yeah, because
patient is underfilled.
Yes, the patient will be presented. There are case reports with transanemic acid having transient blindness. So the patients who have the tendency, because usually the microthrombi which are being cleared, this will be exaggerated in this. So this is the thing which you should be knowing when you are using transanemic acid, even practically.
So how much percentage of hematocrit is generated if you give cell saver blood? 60%, 80%, 70%, 90%?
Yes, this was the question you asked. Yes. And another, I will add one more thing, that are we giving the whole blood through the cell salvage, or are we giving only hemoglobin, or what we are giving actually? What is the
RBCs, washed RBCs through this cell saver, and the content of RBCs are 50 to 70%.
And actually
70%. 60 to 70, I guess.
Yes, actually they have the mechanism. They can concentrate it. Okay, so according to the situation, they can make it a little bit concentrated by just doing the filtration. Okay.
And very basic question: what is ratio of hemoglobin and hematocrit? If you look at ABG, can you tell patient is overhydrated, or is hemodiluted, or hemoconcentrated? Can you tell that?
It is 1:3. If hemoglobin is 10, hematocrit is 30%. And in dehydration, it increases.
So, explain us with example. So, if you do ABG and hemoglobin is 8, and what will the picture in case of hemodilution? Hematocrit will be higher.
Bilal, your voice is very distorted.
I'm saying that on blood gas, a lot of clinicians see blood gas and they say no need to give blood. Patient is hemodiluted. So which trend they see between this hemoglobin and hematocrit, and they say it's hemodiluted, or which trend they say these two numbers and they say a patient is hemoconcentrated?
Yes, Bilal, I think you tell yourself, because we are over time. So I have to finish it.
Hello.
Yes, Bilal, you just explain in few words this thing.
Can you hear me?
Yes, we can hear you.
I cannot hear. Let me come again.
Yes, Tayyaba, can you say something on about this point?
Sir, hemoconcentration means, sir,
No, sir.
hemoconcentration means HMC, sir, mean corpuscular volume, जो है sir.
No, have you understand his question? That when will you say that patient is hemoconcentrated or hemodiluted? How will you say? Actually, I am not. I also don't have the perfect answer. So if anyone wants to explain this thing, that we see the hemoglobin versus hematocrit value, and we say this is hemoconcentration. If it is more, ratio is more.
Sir, I think when hemoglobin, the ratio is 1:3 now. If hemoglobin, the ratio is not being matched and hematocrit is comparatively higher, then we will say that it is hemoconcentrated. Patient is hemoconcentrated or dehydrated.
Yes, Bilal.
Hello.
Yes, Bilal. There is too much noise from background. Bilal, we cannot hear you. There is too much noise.
Hello.
Hello? I think there is some connectivity issue, Bilal.
Hello.
Jamil, you have some other explanation than that?
I agree with Dr. Rabia. It's more or less, it's the same, my concept also, if to check the hemoglobin level, but also,
Yes, Bilal, can you hear
with
us?
the hematocrites.
Yes, Bilal, can you hear us? Okay, I think there is some problem in the connectivity. I think this is the same, like if hematocrit is more as compared to hemoglobin, we will say that this is hemoconcentrated. Am I right?
No, sir, if the hematocrit is, sir, if hematocrit is more than 40, it is mean it is more concentrated.
No, but it is related to the hemoglobin level. You understand? It is related to hemoglobin level.
Sir, they both are interrelated, or the ratio is 1:3, like 10 hemoglobin and 30 hematocrit. 30% should be hematocrit.
Remember one thing. You see the thing which was annoying Bilal as well, and this annoys the examiners as well. If someone has asked some question, you have to answer that question. Okay. If you will be telling something else, this will not be an answer. The question is that when will you say that patient is dehydrated?
Hello. Hello.
Yes.
Hello.
Bilal, we cannot hear you.
Hello. Can you hear me now? Hello.
Yes, we can hear you now.
Yeah. So let's say, Dr. Rabia, if hemoglobin is 10 and hematocrit is 25. So patient is hemodiluted or hemoconcentrated?
Patient is hemodiluted, sir.
Yeah. So that's the answer. So let's say hemoglobin is 10 and hematocrit is 37. So is it underfilled or overfilled?
It is hemoconcentrated. Yes.
Yeah.
Okay. So I think Bilal, we will discontinue here because it's already getting too late in Pakistan. Okay. Thanks everyone for the presence. And if anything is not clear, we can discuss again. We will continue from here day after tomorrow because tomorrow I am busy somewhere. So tomorrow I will not be able to have the session. So day after tomorrow we will continue. Thanks a lot, Bilal.
Sir Dishan?
Yes.
Sir, thank you so much.
Sir Dishan?
So what will be the discussion by tomorrow?
No, the day after tomorrow.
Sir, we want thalassemia, a special thalassemia lecture from Sir Bilal, especially sir on the anesthesia techniques and everything about
no problem. We will continue from here, thalassemia and blood transfusion strategies, different blood products, how they are like different like what will be the different transfusion triggers for everything, and we will also discuss rotom or thromboelastography along with it.
Sir, we are very thankful to Sir Bilal that he has come to listen to us and sir.
No problem, no problem. I have been like listeners like you, and a lot of people were there who helped me a lot, and who just created some thought process, and we started working on that lines. So I guess this is time for us to pay back. So no thanks, nothing. So maybe I feel like this is our responsibility to just disseminate and trickle down all these skills down to the people.
Okay, and a special thanks to our international listener, Dr. Thamer, and all others. I can see some of the names, Dr. Isam, Dr. Ayman. Okay, thanks a lot, everyone. And inshallah, we will continue day after tomorrow, okay?
Yeah, sure. Good luck. Good night. Bye.
Thank you, sir.